Okay, well, welcome everyone to our seminar today. So before we get started, I'd like to offer a land acknowledgement. And as this is a hybrid event and some participants are on different territories, we ask that you take the time and space to express gratitude and respect for the land that you're currently living and working on. Today we're here on the York University campus in Toronto, situated on the traditional territorial area known as Toronto, and we acknowledge its current treaty holders, the Mississaugas of the Credit First Nation. We also acknowledge this as the traditional territory of many Indigenous nations, including the Anishinaabeg Nation, the Haudenosaunee Confederacy, the Huron-Wendat, and the Métis. This territory is subject to the Dish with One Spoon Wampum Belt Covenant, an agreement to peaceably share and care for the Great Lakes region. Welcome. Come on in. Just getting started. So I am delighted today to introduce Dr. Rajnish Ranjan Prasad, and he's joining us all the way from Bangkok. Rajnish holds a doctorate in public health from the University of India, postgraduate certificate in global health from the University of Manchester, a diploma in public administration from the University of York, and a master's in rural management from the Institute of Rural Management, and bachelor's in computer applications from the WLHIV University in Indore. So Rajnish, or Dr. Prasad, is currently working as a program specialist in gender equality and HIV/AIDS with the UN Women's Asia Pacific Regional Office. He has 17 years of experience in addressing inequalities, empowering marginalized communities, and providing technical support to government. He's working with the UN Women Country Offices in the Asia Pacific region to address gender inequality in planning and utilization of health services. He's previously worked with the UNFPA and supported the Government of Rajasthan, India, in strengthening large-scale programs for holistic development of young people, especially girls, addressing gender inequalities, and to promote youth leadership. He's also worked with National AIDS Control Organization, Government of India, and managed large-scale HIV/AIDS programs. Just as a reminder, to ensure that our guest speaker and participants online can clearly hear your questions, we ask that you speak loudly and clearly toward the microphone across the tables, and please introduce yourself. We'll also pass around the iPad so the audience online can see who's asking the questions. So with that, Rajnish, we'd like to hand it over to you.
Thanks a lot, Professor Mary, and thanks a lot, colleagues. Glad to be here, and apologies for trying to get going early for this morning session. I understand normally it's in the afternoon for the other webinars and sessions, but it's around 9:30 here in Bangkok in the night. So yeah, thanks a lot for joining a little early. In this presentation, basically I'm going to talk about these. One, present some data related with the prevalence of the HIV/AIDS at the overall situation in terms of the comparison between global level and the Asia Pacific. The second is in terms of the prevalence of the HIV/AIDS among the women and the trends. Then we also look into some of the other associated factor indicators, especially focusing on terms of the discrimination and the violence, and then look into the structural factors which contributes to the increasing HIV/AIDS among the girls and women, and then look at some of the interventions and the strategies which have worked, and then we'll sum up with the discussion thing. So, and I understand many times this webinar, especially online, becomes a little bit boring. So if you have any question in between, it's please feel free to ask me. With this, if nothing else, I will start my presentation. So I'm currently working with the UN Women Regional Office here in the Asia Pacific, based in Bangkok, and I'm provide the support for the HIV/AIDS program in the region. And Asia Pacific region roughly has around 66% of the world population. So it's in terms of the population terms, is the world's biggest region. And it's often what happens when we talk about the Asia Pacific region, or sometimes we look at the national level, we have the tendency to average out the things. But the region itself is quite diverse, as frankly, most of this country itself is quite diverse. If you take the example of India, the situation of the HIV/AIDS is in North India, in Delhi, is very different what is in the northern and northeastern states. Similarly, in most of the Southeast Asian countries, the nature of the HIV/AIDS epidemic is different. This prevalence among the different population subgroups is different. Even within the region, there is a huge diversity and variation in terms of the prevalence, in terms of the drivers of the epidemic. And if we want to develop a kind of the effective response, it's very important also to understand like what are those drivers at the different at the national level, at the sub levels, and within those different population groups, and then accordingly only we can develop a kind of the comprehensive response to that. So if you look in terms of the overall prevalence of the HIV/AIDS at the global level and the Asia Pacific, in terms of the people living with the HIV, around in 2023, roughly 39 million people were living with the HIV/AIDS all over the world. Out of this, close to around 17%, 6.5 million people are living with the HIV/AIDS in the Asia Pacific region. In terms of the new infected people with the HIV, the number has been declining over the period especially from 2005 in most part of the countries, and it's around in 2023, around 1.3 million people newly got the HIV/AIDS, and out of this, roughly 24% of people were in the Asia Pacific. Similarly, in terms of the AIDS-related death, roughly around 22% of the total AIDS-related death were in the Asia Pacific region. In terms of the people on the treatment, around the same, close to around 20%, 17% people in the of the total number of people living the HIV/AIDS who are on the ART treatment, they are in the Asia Pacific. In terms of the control of the HIV/AIDS epidemic, the Asia Pacific region has done relatively well. But the challenge has one, if you see from 2002 to 2023, the number of new infections since 2010 has declined by around 13%. But this progress has been actually slowing down in the last couple of years. And so as of now, it doesn't seem that the region is on track to achieve the 2030 SDG target of ending the HIV/AIDS epidemic. And especially in some of the countries, as you will see in the next slides, we are seeing that the epidemic has been increasing also, which actually pose a major challenge. And this trend is quite troublesome, especially at the same time, this trend is taking place when the financial resources or the focus on the HIV/AIDS has been declining globally and in the Asia Pacific region also. And this decline has also affected to some extent of the slowing down the trend, because the most part of the funding, especially which used to come from the community-based organization, and the prevention part used to come from the external donors like the Case Foundation, from the Global Fund, from the PayFor, which has been significantly reduced for this region. And while the local funding has been continuously improved by increased by the governments, most of these fundings are going for the treatment services. So the prevention and especially the community mobilization part, community level advocacy has been affected in last 5 to 10 years, which has also resulted in somewhere hampered the utilization of the preventive services and resulted in the slowdown of the declining the HIV/AIDS new infections. I think it's also very important to understand in terms of the HIV/AIDS when we talk about the challenges, because whether we talk about the young people, we talk about the vulnerable women, we talk about the sex workers, the drug users, the messages need to be continuously keep on reinforced. There is also turnover in terms of the sex workers, in the terms of the drug users, the young people. So, and behavior change is also probably one of the most challenging part. So you have to keep on continuously reinforcing the message, the importance of actually using the condom every time, every sex. And with the decline in the resources and the overall effect on the prevention services, those reinforcing of the messages has been somewhere hampered. And this has resulted in the slowdown in terms of the decline in the resources, HIV cases, sorry. So if we look into the terms of the country-wise variation of the overall prevalence of the HIV/AIDS from 2010 to 2022, we see most of the countries in the region has actually is like the HIV/AIDS has declined significantly, but some of the countries on the right-hand side, the HIV/AIDS has been also increased significantly. especially we take the case of the Philippines, where it has been increased by 418% in the same period. The challenge is also, it has been, this increase has been taken at the same time when there has been a lot of initiatives or forceful measures taken by the government to control the drug use. This has created the new sort of the challenge as most of the drug users gone underground. It becomes very difficult to provide the services to the drug users, and hence we see there is the rapid increase in the HIV/AIDS. Similarly, if you take the case of the PNG and Fiji, these are the countries where again the drug HIV/AIDS has been increasing among the drug users and also among the women. And these are the countries where actually the prevalence of the gender-based violence is quite high. Close to 50% of the women has said they have experienced some kind of the violence in last 1 year from their intimate partner. So, and we know that actually gender-based violence is one of the major contributor or structural factor which contribute to the prevalence or the new infections of the HIV/AIDS. In Afghanistan, it's a different story where the health system has virtually collapsed after the Taliban. Similarly, in the Bangladesh and the law PDR also we see, because there is a kind of the increasing discrimination and stigma against the sex workers among, and also many of these countries in last couple of years, when the right-wing governments have come into the power, somewhere the comprehensive sexual education has been affected. And this is also affected the providing this information on the HIV/AIDS, in the information on the need of the safe sex and its importance, which has contributed into the increase of the HIV/AIDS in these countries. So somewhere all the reasons and the drivers of the increase in these countries are quite different. At the same time, they also have the quite similarity that is also related with the stigma and discrimination, with the gender-based violence. So, and lack of the resources, lack of investment, especially in terms of the community mobilization. In this slide, we are looking into the gaps in the terms of testing and treatment. UNAIDS has set the target is called 95, 95, 95. So when we talk about that 95% of the people who have the HIV, they should be aware of that they have the HIV. Out of those 95% of the people who know should be on the ART, and out of this 95% of the people who are on the ART, the viral load should be suppressed among them. What we know is that if the viral load is suppressed among a person living with the HIV, the person is not able to transmit or pass on to the HIV virus to another person. So somewhere the suppression of the viral load is very important. So in terms of the absolute percentage term, it's come to 95, 98, and 86%. But the region is lagging behind, and these in terms of that, and especially in terms of the people living with HIV who are on the treatment, is around, against the target of 90%, we are already, it's like 65% have been achieved. Similarly, against the target of 86%, only 62% progress has been achieved. And this progress has been slowed down in last couple of years, which is quite a challenge. And the indicators are roughly same, around same for both women and men in the region. When we're talking about the 95% of the, it's like looking to the previous slide, again, the problem is the average heights, is like the country-wise variation. So you can see the countries as New Zealand, Cambodia, where it actually is like the progress is more than 86% in terms of the coverage of the ART. Then you see on the other hand, the countries like Afghanistan, Pakistan, and Fiji, where it is less than 30%. And a significant number of the countries in between 32 to 41%, which remains the challenge because the countries like Indonesia has a huge population. Similarly, the Philippines, which has got the 418% increase of the HIV in last 12 years, it's like the coverage of the ART remains 41% only. So somewhere the ART coverage need to scale up in the region significantly. Also, if I'm too fast, just let me know. Sometimes I have the habit of going actually too fast. Now we come to in terms of the HIV prevalence among the women. So in 2020, it's like around 2021, 2.1 million people, women were living with the HIV/AIDS in the Asia Pacific region. The number of new infection among the women has been declining for last, especially after 2005, close to that. The decline has been significant, but in last 3-4 years, we see that this decline of the new infection has been actually sort of plateaued and the progress has been slowed down. The number of the AIDS-related death among the women has been also declining significantly. And Also, Asia Pacific region is quite different from the African region, where in Eastern and South African region, we see that the prevalence is actually of the HIV/AIDS is more among the women, close to around 51 to 52%. While in the Asia Pacific region, it's close to around 35%. In Asia Pacific region, the most of the HIV prevalence, or close to 97% of the new HIV cases takes place among the key population and their partners. Though the women remains vulnerable significantly because one, within the key population groups, we see there are the female sex workers, the transgender women, and also the female drug users who are highly vulnerable. And women also is like, because as the partner of the key populations or get severely affected and also get the HIV/AIDS. Then we look into the terms of these, especially the comprehensive knowledge of HIV/AIDS among the both male and female, and we'll see again the significant variation, and especially if you see the countries like Bangladesh, the Timor-Leste, Pakistan, which is also showing a kind of the increase in the HIV prevalence. Uh, the the comprehensive knowledge of the HIV/AIDS is quite low among the both male and female, and also the challenge is like, if you see some of the countries, the data is actually quite old, 2017, 2016. So somewhere with the reduction, the focus on the HIV has reduced. That's also affected the like central and surveillance, and the data collection has become less frequent. So for many of the indicators, when we talk about this, especially in terms of the knowledge, in terms of the stigma and discrimination, the most of the data which we are still using is actually 6 years, 7 years, 8 years old, and that's also challenge that how to use it for the programming purposes. Uh, then next we look into the terms of this, like the use of the condom during the last sex, especially among the people who has reported having the multiple sex partners. And this has also been quite low in some of the countries, especially if you take the case of the from PNG, Timor-Leste, Fiji. Then we talk about the Philippines. Again, these are the countries where actually the HIV/AIDS has been increasing in the last couple of years. So somewhere both in terms of the knowledge is low, the violence level is high, stigma and discrimination is quite high, which actually contribute also to the low utilization of the condom. When we were working with the female sex workers, especially many of the time the female sex workers, that doesn't inform in their families that actually they are engaged in the sex work. So they doesn't like to carry the condoms along with them. So they're afraid if anyone could find in their homes, then they might have to face the violence from their partner, whether from their family members. And then it becomes quite important that you provide the different services. One, either it's like the condoms are provided to the sex workers near to these places where they solicit the client, or you have a facilities like the drop-in centers where they can drop in any time to pick up the condom. And if those services are not there, then we've observed that the condom utilization is quite low. And so providing these services as per the need and as per the time where they utilize it is quite important. Uh, and this slide actually presents the data related with the prevalence of the intimate partner violence, and the outer circle shows is the number of percentage of the women who ever experienced any intimate partner violence, and while the orange circle, the inner circle, shows the women who have experienced violence in last 12 months. And again, if you show the countries like PNG, the Timor-Leste, the figure is close to, in fact, more than 50%. So the prevalence of the gender-based violence, especially, and if you consider it's like the cases of the women who experience violence ever in their lifetime, it's more than 50% in many of the countries in the region, which shows actually that the gender-based violence is quite prevalent. It's also because of the existing gender norms, and the societies are quite patriarchal in nature. And even if you take the surveys of finding related with the acceptance of the violence is quite high. Even the women, if you do the survey among the women, they can, whether it's like they consider is normal the practice of having the facing some kind of the violence or the abuse from their partners. So, and that remains a challenge, especially trying to work, and that's also highlight the need to work on the gender and social norms, uh, in order to address the both gender-based violence and ultimately the HIV/AIDS. This slides look into the terms of the proportion of the female sex workers who experience the physical violence. The, the percentage of the female sex workers who experience any kind of the violence is actually quite high in most of the places. Uh, Again, there is most of the countries at the national level doesn't collect this data. So we'll have to look into the data from the different sites which are collected by either the NGO or the surveys done by the other donor agencies or the national AIDS control authorities in these respective countries. And this shows in main part, actually the prevalence among the violence among the female sex workers is quite high. And often this figure is underreported because the female sex workers are afraid of reporting the kind of the physical violence against their client. Often they are afraid that actually if they report, especially to the law authorities, or if the issue comes out, they might be the one who has to face the legal challenges. So sometimes, most of the time, actually the figure is quite underreported and the actual prevalence is much higher than this. And in the later slides, we also look into that how the gender-based violence and actually affect the capacity, ability of the woman to, one, to negotiate the safe sex, to use the condom, or even to access the HIV/AIDS services. Then the another challenge is like many of the women with the HIV in the region face is in terms of the coerced sterilization. So because of the existing stigma and discrimination and the when the women with the HIV, if they become pregnant or they want to have the children, often the service providers actually force them to undergo sterilization. The general thing is that they should not pass on the virus to the child, or why should they spoil the life of its child. So it's many times they are not even able to access the PMT services to ensure that to avoid the passing on the virus to children. And that's also come down to actually terms of the existing norms which or the biases among the service providers in the healthcare settings have these women with the HIV. And those biases have remained constant in most of the countries. And despite of the efforts which has been taken in terms of the orientation of the healthcare service providers, we do see it's like once we orientate them, there is a sort of the improvement in the behavior of the healthcare service provider. But over the period, if we doesn't continue keep on reinforcing the messages, either there is some kind of the goes back to the earlier practices, or sometimes when the healthcare service providers get transferred or change, it becomes difficult for the women with the HIV again and to again access the health services. Then this slide present again the data is quite old because the challenges remains is like because most of the services are not now collecting the data related with the stigma and discrimination or the coercion against the women with the HIV. So what the old data shows is the prevalence is quite high. The challenge is because of the lack of the current data, it becomes very difficult to use it for the program planning purposes. Then it's also like when we talk about the woman itself is not a very homogeneous group. There is a huge diversity within the women, and there are the groups and the subgroups. And some subgroups, especially, is like more face much more higher level of the stigma and discrimination because of their sexual identity, because of the existing biases and the gender norms. And transgender women generally face much more higher level of the stigma and discrimination and the violence. And especially with to show some of the findings. In India, it's like 20% of the sex workers, transgender women has reported that they have experienced some kind of the sexual violence in the last 12 months. In Bangladesh, 25% of the transgender women reported that they were raped in the last 12 months. In Cambodia, 20% of the women, transgender women have reported they were either denied or thrown out of a housing in their lifetime. Similarly, in Pakistan, 1 in 6 transgender women have been denied health care in their lifetime. So the transgender women actually face much more higher level of the stigma and discrimination and the violence, along with the female sex workers, or because of their sexual activity, because of their identity, gender identity. And so when we even have to develop the interventions, we'll have even these transgender women, when we try to access sometimes they face the problem even from the other women. So especially when we talk about the shelter homes, if they face a kind of the violence, and if the transgender women is actually is like refer to the same women shelter homes, often they face the challenges where the women within the shelter homes that doesn't accept them. So providing them the services in case of the violence also becomes much more challenging. Now, if we are going to look into some of the structural factors which contribute to the drivers of the HIV, we have been talking about some of the drivers, especially looking into the terms of the stigma and discrimination and the gender violence. So one we already know is like gender inequality and violence, and it actually affects the women at the multiple level. One, it limits their choice. Often the woman faces the challenges is in terms of the using the condom. Sometimes, especially when they try to use the condom with a regular partner, the partner is not uh, willing to do so, and women often lacks the agency to force the partner to do so. Then it's also their existing vulnerability because of the fear of the violence. They are not able to use the condom, or they doesn't want to go to the access the HIV services, especially when the pregnant women, when we talk about, so like, at times they deny the HIV testing during the pregnancy or antenatal care services because they are afraid if their HIV status known, they may they may have to face the violence from their partners and the other family members. So it's affect their both in terms of the limit their agency and also reduce the utilization or uptake of the HIV prevention services. Then poverty or socioeconomic status. It's also undermined their capacity during the COVID-19, especially. We also seen because of the lockdowns, many sex workers doesn't get any clients. So even the sex workers who earlier used to negotiate, ensure that they use condom every time with and every sex, they were forced to actually, if the clients were asking that for sex without the condoms, they were forced to do so because of the need, ultimately the money. So somewhere because of the poverty or the lack of the money reduces their negotiating capacity and forces them to engage into the risky acts. Alcohol use. Studies clearly shows that actually it's like whether the clients or the women, if they both either one of them or both of them use alcohol, it reduces their ability to use the safe or to practice the safe sex. Then stigma. Because of the stigma, the female sex workers, the transgender women, they were not afraid. They are not willing to go to the HIV health services to access the HIV services. HIV itself services itself is quite stigmatized. So somewhere people or women prefer to actually not when to go to the health, especially when we talk about the public health facilities, they are quite afraid of going to the those health facilities in order to access the both prevention or the care services. Then we also have the tendency that if the woman demand for the sex, somewhere we, especially in this part because of the gender and social norm, everyone raises the question on the morality of the woman. So that's also make it much more difficult for the woman, especially to ask for the condom from a pharmacy, from a healthcare service provider. Uh, Especially then we'll already talk about these like the in terms of the impact of the women. So the studies with the pregnant women shows that the anticipated, sorry, expected the violence from the intimate partners is one of the reasons that they generally refuse the HIV services, or the fear of the uh, disclosure is a major barrier in the uptake of the PMT services. They doesn't want anyone to like know about that they're HIV positive. Then it also reduces their uptake of the antenatal care services, and the women in with the history of violence have found to be have less breastfeed their children in comparison to the women who have not have the history of the violence. Similarly, when we talk about these studies done among the HIV positive women, if the women are afraid that that their HIV status will, if the others, their partners or the others will come to know about their HIV status, it's like they have to face the violence. They would prefer not to access the HIV/AIDS treatment services. Then it's also lead to the poor adherence. It's like we often see one of the dropout is from the ART services is much higher among the women who face any kind of the violence than the women who have not. It's also has been low to one study shows that it's been related with the overall poor health among the women, especially also including the lower CD4 counts, and they have the more higher prevalence of the opportunistic infections and the STIs. This slide shows actually the benefits of addressing the gender-based violence. Uh, so if we are able to address the gender-based violence of the women, it contributes to actually to all the SDGs in terms of that we know that it's the women who face any kind of the violence, the poverty level among them is higher. So and ensuring that addressing those violence also contribute to ensuring their overall well-being, reducing the hunger, overall health, the utilization of the health services. They are much more um, prone to continue their education, and it contributes to the gender equity along with the decent work and the reducing inequality. And most importantly, it's also contributed to the reducing the like the behavior related with the HIV/AIDS, including the early sexual debates or having the higher number of the partners, or in terms of the engaging into the risky sexual acts, having this or having the transactional sex, or the sex without the condom. So somewhere, especially when we talk about the, I think two factors which remains very quite important is one, the gender-based violence, and addressing a stigma and discrimination at both at the community level settings, in the family settings, and the healthcare settings is quite important in terms of if we want to address the challenge of the HIV/AIDS among the girls and the women and improve the uptake of the HIV prevention and care services. Now we are going to look into the terms of the some of the strategies which has shown to be work. We know that actually the integrated economic and gender empowerment interventions works much better than the isolated interventions, because if the women have the money, uh, they are much better positioned to both negotiate for the safe sex and if they face any kind of the violence, they are able to reach out to the service provider to access or to the legal authorities for the uh, support. And it's also in terms of the contribute increasing the utilization of the HIV prevention and the care services. Then collectivization. I think one of the major success of the HIV/AIDS movement in most part of the world that is able to give the voice to the some of these most marginalized groups, including the LGBTQ communities, female sex workers, the drug users, and the major cause was that the collectivization. When the women and the affected communities were able to come together, they were in much better position, one, to in terms of the establishing the norms in many places in India and the other settings, we saw that the women in the brothels, the sex workers, they themselves decided that the no sex workers will have a sex without condom, and it forced the client to actually use the condom because they were not none of the sex workers were were willing to have the sex without condom. Similarly, it's like if they are collective, they are together, they are in much better position to undertake the advocacy with the legal authorities, with the for the service providers for their rights, in order to ensure that the services are provided to them in an environment which is comfortable to them. And second, we also see that because of the collectivization, they were able to raise their demands in much better with the policy makers, and which has contributed in improvement their overall well-being. Then training and sensitizing the gatekeepers and the communities, engaging the other stakeholders, which act as a gatekeeper, is also kind of important, especially engaging the legal service providers and police and the healthcare providers. We do see it's like that engage communicating with the police on the regular basis by the women groups, but has actually contributed in terms of the both addressing some of the biases and the discrimination which this women with HIV or the vulnerable women or sex workers has to face, or the discrimination they face in the healthcare settings. Then even the attitude toward the media and the journalists in terms of the way these news are reported has also been changed because of their regular engagement and sensitization. Then providing legal, social, and services for the violence and establishing a response mechanism to facilitate reporting and resolution of incidents of violence has been found to be very effective, especially in terms of the referral to the shelter homes, because one like when a sex workers or the women with HIV face a kind of any kind of the violence, within their household from the intimate partner, the first their priority need is to have the shelter. If there is no shelter is available for them, then they are forced to live within the same household under the same room with the person who has actually initiated the violence. So providing those shelter homes, referral to the shelter homes, then providing them the legal services and linking with the health services is quite important in order to both reduce the vulnerability to ensure that they have they can access the services when they need it. Then documenting the cases of the abuse and conducting advocacy for changes in law is quite, especially the documenting the abuse is quite important, because most of the times the challenge is like most of these cases are the verbal, they are the stories, but there is lack of the evidences, and the documentation of this abuse actually helps in bringing one, it helps in undertaking the advocacy, and those bringing those evidences to the legal authorities, to the policymakers, to the service providers to bring those changes and to bring have a kind of the tangible action over those cases. Then the evidence, the interventions which engage the men and boys has been found to be quite effective in terms of the changing the gender and social norm. But again, there are the separate sets of the studies which shows that how those intervention has to be implemented. Otherwise, merely engaging them doesn't alone itself give the desired result. Then changing the unequal and harmful norms through the community mobilizations, especially when we talk about the norms related with the sexual use, and the taboos related with the HIV/AIDS. Then trying to somewhere reducing those stigma and discrimination, ensuring that the women are able to access the health services, they are able to reach out to the HIV prevention services is quite important. Then social marketing, especially delivering the services through the pharmacy, distribution of the condoms, or the behavior change communications. But the behavior change communications need to be done in the proper way in the settings where the target is recipient to those messages is quite important. Then last two strategies when we talk about one, when we talk about the linkages of the HIV prevention and the treatment services with the violence prevention and the violence referral services is quite important. So when the women have faced any kind of the violence, often their first need is of this shelter, or often the healthcare service provider is actually the first point of the contact where there is. So if we are able to train the healthcare service provider to identify those symptoms of the violence, refer to the women to the shelter homes, provide them the legal services along with the HIV prevention services, then we are in much better position to prevent the HIV/AIDS and to reduce the burden of the HIV/AIDS among the women. Then addressing the intersection of the violence against the women, alcohol use, and the HIV rates, HIV risk actually is like reducing the both in terms of the alcohol use and the gender-based violence. Often the violence is actually also accompanied with the alcohol use. So somewhere working at the intersection of that is contribute also reducing the HIV/AIDS. Next, we are going to look into some of the community strategies which have been found to be quite effective in terms of that. One, SASA is a community mobilization initiative. It started with the NGO in the Uganda, and then now it has been actually the initiative has been rolled out to the and adopted to many parts of the world, including the Africa, including the Asia Pacific, in the different setting, and is moved beyond the HIV/AIDS itself to change the gender and social norms. So the initiative work focuses on bringing the whole community together and have a reflection on the existing norms and the power relation, and then try to, through this process of the reflection, it tries to change those norms and the power relations to ensure that the women have the equal rights and they have their own say and their rights are protected by engaging the different stakeholders. And this model has been found to be quite successful, and it's been adopted in the different settings from in terms of the utilization of the other health services, in terms of to reduce the gender-based violence, to change the gender and social norms at the community level. Another initiative which has been found to be effective is in Ethiopia. NGO started an initiative, a kind of the radio program of the young sex workers, where it's a radio diary where the young sex workers they talk about their lived experiences, and this actually helps to break down a kind of the widespread stigma and discrimination. It has been it was received positively by everyone, including the police authorities, and it's somewhere changed the broader acceptance of the understanding and acceptance of the rights and needs of the women who sell sex. then the another initiative which was done in the Kenya by NGO, and in order to address the negative gender norms, they reach out to the community members. They have conducted the different focused group discussion with the community to understand that how the positive messages can be communicated, which were later validated through a workshop with the community champions, and those positive messages then helps in creating kind of the positive gender norms. So the idea was to have the generate the messages which is as per the local community needs, which are respectful to the local cultural norms, and at the same time they address those issues. So the messages need to be developed as per the local context in order to ensure that these messages are quite effective in terms of the bringing the desired behavior change among the target population groups. I think that should be the end of my presentation. That's all. Thanks a lot.
Well, thank you so much, Rajnish, for that really actually powerful presentation of both, how actually widespread HIV still remains, especially in the South Asian regions, and also some of the community-based strategies that are arising to try and change norms, because in the end, it's those norms that really influence behavior. So just as a very first question, I guess for those community projects that you highlighted, are there publications that document the processes, or is this basically from your own experience?
No, I think there is actually very good documentation of the several of case studies. It's like in terms of, so we'll be able to share that. I remember even London School of Hygiene and Tropical Medicine used to have a project called Strive, which got over a couple of years back, but they also did some very good documentation of in terms of the different approaches which has been found to be effective, including the community mobilization, including using sport as a medium of change. So each of these initiatives have their own strengths and weaknesses, but there are, I think it's also important, one point which not been that when we talk about these changes, especially when we talk about the gender and social norms, when we talk about the behavior change communication or changing those norms which has been there for a very long time, these processes are very long. So now whatever the results we see has been actually because of the efforts of many people for the over a period of 5 years, 10 years, 15 years. So the community mobilization models which we see in India, in Sonagachi and other places which have been replicated now is because of the initiative which has been taken over the period of 5-10 years. So somewhere those investment is very important. But yeah, there is some very good documentation is there. So while replicate this model can be, when the study shows how much these models have been effective. Yeah.
Okay, that sounds really interesting, and I would love to follow up with you to maybe you could share those some of that documentation. Just to let you know, some of us are thinking of developing a proposal to to create policy change through community. So this would be very powerful, and So let me turn it over to the class and our online participants to see if there are any questions.
Thank you. Hi, Dr. Rajnish. Thank you for the really insightful presentation. Definitely learned a lot in terms of the Asia Pacific, kind of what's going on in the Asia Pacific scene. I just wanted to ask 2 questions. So firstly, I wanted to touch on the funding. I know you said that funding towards HIV has decreased, and that's something I've noticed here as well. I work in the community setting when it comes to HIV prevention, working with community members, and we've also obviously noticed that funding has decreased significantly over the years. And even though, certain things are working, the government still decides to kind of take away that funding, and we're kind of lost and trying to figure out what to do next. So first I wanted to ask what kind of advocacy, I guess, is being done over there to kind of continue getting that funding to work towards that 95, 95, 95 target, like if anything is being done. And I also wanted to ask about, so I wanted to touch on, the challenges that women face when it comes to advocating for, negotiating safer sex, negotiating the use of condoms, because I know, obviously, as you mentioned, sometimes they're not able to negotiate the use of condoms. And so something I came across recently was the dapivirine vaginal ring, which is, so it's something that's been approved, I think, only in Africa so far, like Zimbabwe, for example. And I think it's been approved by WHO, so I was wondering if it's something that has been approved anywhere in Asia, or if it's something that is being worked towards, if that makes sense.
Yeah. Thanks a lot for the question. Yeah. So shall I go ahead with the answer, or you want to take more questions?
Maybe, Aurita has suggested 2 questions, so maybe, I would go with those, and then we'll see what comes up after.
Sure. Thanks a lot. So thanks a lot for your question. So first part, when we talk about in terms of the HIV/AIDS funding, the trend has been declining. The funds have been declining for some period of time. Somewhere post 2010, it's been an issue. Couple of the things which we have been trying to do. One, there is a lot of engagement with the government, especially to increase the local funding by the government. And the funding, especially in the Asia Pacific region, we see that the funding has been increasing from the government. The challenge is most of these funds are going for the care services, for the treatment services, because as more and more people actually coming onto the ART and moving from the first to second and second to third line of the ART, which is much more costlier. So the money with resources has been going more. It's the prevention services, especially the funds which is going to the community groups, which has been challenging. So as part of this, we are also trying to work with we have something called the joint UN team on the regional level, and then there is a joint UN team at the country level at each country office, at each country, which try to work through the resident coordinator office to work with the government in terms of to get mobilized more resources. Then we are also working with the global fund in terms of to ensure that there's the more fundings are available through the global fund to civil society organization to undertake the advocacy. But yeah, again, the challenge is especially the small civil society organizations or the community groups are worst affected because they also lack the ability in terms of that. So, but that's frankly is challenge. And while we have been trying to work with the government and the other donors, trying to also try to bring some more private sector funding, then the another point which may not contribute to the funding for the community organization, but overall it's try to push the HIV/AIDS strongly under the umbrella of universal health coverages. So ensure that the health insurance include the provision of providing services for the people living the HIV also. So somewhere those economic burden is actually reduced. So I think that's the first part. In the second part, yes, when we talk about the vaginal ring, I think in several of the countries, it has been also been going on as a pilot use. The challenge is most of the government till now has initiative is not included that in their program or the commodities which is procured by the government at the national level. And for its large scale adoption, I think that's very important, and the advocacy is being undertaken. I think the another thing which is quite useful with the PrEP, in terms of the new injections of variation of the PrEP which are coming now. It's you need probably one injection over the period of 6 months, which may be actually a game changer in terms of that. But again, the challenge will remain. It's how wide will be this, whether the government put in their money for it or not, because to large scale adoption or the large scale, ultimately the government has to come forward and they put in money over there. But if they are able to do so, then I think that could be the game changer. But it's still, I think some basic messages, especially when we talk about the condom or when we talk about the comprehensive sexual education, that remains important, because while the PrEP or the vaginal ring provide you prevention from the HIV/AIDS, for the STIs and other diseases, the condom still remains the most basic prevention method. So somewhere I think that the comprehensive sexuality education is still probably will remain important. But yeah, from the HIV perspective, I think next 2-3 years, especially with the adoption of the new PrEP medicine, I think could be a very different game changer. Yeah, thanks.
Just to follow up, if I may, so what you just referred to, the PrEP, is that for prevention or treatment?
Yeah, PrEP is for the, actually, PrEP was initially for the treatment, then it also realized that if you take the medicine, because it also reduces your chances of getting the HIV significantly. So PrEP from the treatment actually moved to the prevention part. But initially it's been recommended for the people who actually uh, who have multiple partners or more at risk because of the associated cost. And it needs current PrEP medicine need to be taken regularly every day. So that's a challenge how to ensure that. But the new variations which are coming, I think the injection need to be taken once in 6 months. And that will be, I think, will be very helpful. Both it will reduce the cost and it will be much more convenient.
Yeah, I agree. That would be a game changer if implemented to those vulnerable groups. Yeah, great, thank you. Let's go online. Sandra, you have a question or comment?
Hi, can you hear me?
Yes.
Yeah,
perfectly fine.
hi.
Thank you.
Great, thanks. Thank you for your talk. It's such a vast landmass and a groups of folks that you're drawing research from. I'm just to say I'm a faculty colleague in anthropology here at York. And so my question, and I've worked in Vanuatu for some decades on reproductive health and the effects of colonialism on health. And so one of the things I have two questions for you. First of all, what about religion as part of the social context in which these measures are being taken or are not taken, especially because you're considering this huge, very diverse, I don't even know what to call it, continents, land group. Yeah. And then secondly, it's great. I applaud the emphasis on gender-based violence that you have in this talk. That's borne out in a lot of the medical anthropology about the region as well. One of the things I wanted to ask about, or just to say, is that gender-based violence changes over time, and it's not like an inherent part of people's culture. Yeah, so that like, yeah, like there were times when women had much more power in many Pacific Island cultures, let's say, but because of colonialism, because of capitalism, because of some aspects of religion, that has changed the culture and to the detriment of women. It's affected land, access to land, for example, which I also wanted to say that economic empowerment is really important and money, access to funds, but also, because you pointed out housing, just to say that also access to land, which is sometimes determined by kinship, etc., is also important in that sense. And so with all of this from my local knowledge, it occurred to me as I was listening to you talk that my research has really benefited from these big, broad scale, like sort of bird's eye view scale. And yet so I just wonder, like, what are your thoughts about how these big scale reports can also benefit from the local knowledge of what medical anthropologists and other qualitative researchers who work at local scales have? So what are your thoughts about how different scales of research can interact with one another on this important topic?
Thank you, Sandra. Okay, so, and that's quite a difficult question. So more of a program person is sometimes actually it's like difficult for me to get into this academic discussion. But I think it's very important that many of these actually, when we talk about the broad level knowledge, it comes from the community level knowledge. So when we talk about that, the community mobilization is quite effective in terms of the reducing the HIV or empowering these women. So I was working in a project called Sonaga in the West Bengal, and then we are in the Mysore, where we look into the terms of that the working that how the collective this community mobilization has actually helped in terms of the both reducing HIV, and mostly it's like about enforcing these norms regarding the safe sex, that the sex worker should not have the sex without the condom with the every client, and because every sex, all the sex workers come together to enforce those norms, how the condom used significantly. So somewhere those norms, both when we started initially in Calcutta in India, but I'm talking about, we'll probably refer to some examples from India because I've initial part of lot of, especially my field work was done over there. So it's like when we talk about the community level, so those interventions started and found to be successful. Then they also broadened the guideline to the national interventions and both contributed to the knowledge. So when the National AIDS Control Program phase 3 started 2007, 2012, it set up the target that 1/3 of the project should be transferred to the community-based organization from the existing civil society or the NGO model. So because of those one or two model from the community level knowledge, we're actually able to have significant input in terms of that. And then later on, when we talk about we have moved from those learnings. Now, when we talk about that, the community level ownership, we talk about the community level monitoring. So we have these groups at the in most of the countries where they like civil society, the community organizations are engaged in terms of the monitoring the programs at the field level. Then you set up those platforms to engage those feedback from the community level organization with the service providers. So try to bring those small community level knowledge, both in terms of the policy, in terms of the knowledge, in terms of the guidance program. So somewhere, whatever the success actually we are able to see is because of those small knowledge, which actually is like picked up and being adopted at the national level, at the regional level, and then at the global level. So I think somewhere it has been actually HIV/AIDS program probably like I say probably once I was asked a question and that what is the greatest advantage success of the HIV/AIDS program, and for me it was not about the reduction of the HIV/AIDS cases. It's also that actually these interventions empowered some of the most marginalized communities. Before this, actually there was not much talk about the LGBT communities. HIV/AIDS intervention actually brought that money and those resources first time. And then we talk about the sex workers. We started talking about the female drug users. So somewhere those intervention communities, first time they got the attention actually, and the money and the resources were put into those empowering them. And those learnings then actually informed that. The interventions which now we are implementing. Yeah.
Thanks. And just my first question, thank you for that answer. But like first question about religion.
Religion is quite important and it has been important, and we try to engage through when we talk about the community level interventions. And I think religion is getting more and more involved, especially in this part, because somewhere we are seeing that the religions is actually getting more conservative. The challenge is now we are facing is like instead of moving forward after 20 years, actually we are going backward. So those like the acceptance. So I think the engaging the religion is actually much more important. But how to do that now? It's actually becoming more difficult. People are getting more close, more conservative, and moving more toward right wing. So I think that's becoming quite difficult. But the initial part of this, we are quite successful because we are able to engage also the religious leaders, the work which has been done with the faith leader. But at the same time, the work has been faith leader also found to be a little challenging. One, because they were more conservative, and also it's like engaging them at times, especially when we talk about the safe sex, those things want to be the more challenging part. Yeah.
Thank
So
you.
there's
Thank
no
you.
straightforward answer for that.
No,
Yeah.
and thank you too for staying up late for us and giving us this talk.
Thanks a lot.
Yeah. No, fascinating. And I know U.S. policy, American policy, they have certain prohibitions, for example, around, I think even contraceptive use. So
that's a frankly stupid policy. It was there for very, very long time. So even when the USAID used to implement HIV/AIDS program, they doesn't used to, it's like provide the condoms. So it's like the USAID will fund the other services, but the condoms will be provided the Gates Foundation or the other donors. And it's like the ABC, their abstinence and those things. Frankly, it never worked. But yeah, the policy is still there. The problem is like not all the policymakers are smart people,
Yeah, it's unfortunate that those kind of things get in the way with effective approaches. So
yeah.
Anyway, so this brings us to the end. Oh, maybe one question from very quick. No, but
Hi, Dr. Rajnish. So this is Dr. Kadirved. I'm basically from India and a community physician, and currently now I'm doing my PhD here in global health. So I have a couple of questions, but I just prioritize only one question, which is related to the structural driver, which you mentioned, structural driver for HIV, where as a layman, I was just seeing that whether I was asking a question of myself, whether I was taught about the general body composition and also the sexual components of my body when I was studying my schools. And so I was kind of thinking that that is one of the important structural drivers for prevention and management of HIV. And as at least in Indian context, where the two important things, one is the general women education, and the second thing is the sexual education. So these two things. So whether there is any kind of initiatives taken to impart the sexual education in any of the countries in Asia Pacific region related to which is going to kind of help in HIV prevention.
Thanks a lot. So in terms of when we talk about the sexual education, I think actually most of the countries implement some kind of the intervention at the different form. So depending upon their own comfortability with the issues, is called the different thing in the different countries. It's like in India, many states implement something called the life skill education, which also include along with the other part, the sexual education in terms of the changes in the body, in terms of the issues, along with these like how to manage relationships and those things. Similarly, in Indonesia, it's called family education. So it doesn't basically, no one wants to talk about the sex. So it's like as long as you remove the sex from the heading, it's fine. So, but it's been implemented in the different form in most of the countries. The challenge is like often when we talk about it's like delivery of these contents. Often these teachers who are delivering those contents, they themselves are not very comfortable on talking about these topics. So they prefer to, it's like just pass through it, ignore it, and I think that's a major problem. But in terms of the implementation, in terms of the policies, it's being there as part of the curriculum. Most of the state boards have some form of these, like the sexual education in their curriculum, though it's been called in the different names. But I think the main challenge remains the delivery part, that how to be a part, and the teacher themselves are not comfortable. That makes it quite challenging. Thanks.
Thank you. Thank you.
Okay, well, thank you so much, everyone, for participating, and thank you so much, Rajnish, for that great presentation. And I guess our students could follow up with you if they have further questions.
Yeah.
So again, thank you for sharing your expertise and your experience across the Asia-Pacific region. And well, all the best to you in your work, and we look forward to following up.
Thanks a lot. Okay. Thanks a lot, colleagues, and have a good day.
Thank you so much. Yeah, maybe we'll one round of applause. Thank you, and take care.
Thank you. Thanks a lot.